Hey, welcome to Overlooked, a podcast with a point of view that women's health cannot wait. If you want more of that point of view and the backstory to this episode, sign up for my newsletter at overlookedpod.com. That's overlookedpod.com. Hey everybody, this is Overlooked and I'm Golda Arthur. Earlier this year, we did an episode about migraines, and it seems like it really resonated with you guys.
It's just like pounding. It moves all around my head. It's like in the back of my head, the front of my head, my sinuses. I'm really nauseous, and I'm starting to feel worse and worse. I need to go to urgent care because the pain is so bad, and it's been so many hours, and it is not abating.
My guest on this episode was Sally Herships, and she told a really visceral story about what experiencing a migraine actually felt like.
I cannot even tell you how bad that feels.
If you haven't heard that episode yet, we'll link it in the show notes so you can listen to the full thing, like Courtney Martin did.
Hi, Golda. It's Courtney, one of your very enthusiastic listeners.
In addition to being an enthusiastic listener, Courtney is an author and a podcast host and a friend and close collaborator. After Courtney listened to the episode on migraines, she sent me this voice memo.
I love the episode on migraines, although I have to tell you it made me a little nauseous to even listen to it, which I wondered if other listeners had that experience, because I have had migraines. I have puked in New York City cabs when I tried to push myself beyond the migraine. And so anyway, it hit a little too close to home. I would love to request a follow-up episode where you talk to a particularly sophisticated neurologist on hormones, like someone who actually takes this intersection of women's hormonal life and their migraine health seriously, and have them tell us a little bit about what we can know, advocate for, et cetera. I have a daughter who's about to go through puberty, and, we have this genetic propensity for migraines. I think in perimenopause, although now I'm confused what perimenopause is and isn't these days. So anyway, that's my request to the fantastic Overlooked team is, can we talk to a neurologist who gets hormones? Thank you.
So here is that follow-up episode on migraines. In fact, that's not even what I should be calling it.
So the language update is that we stop calling it migraines and we rather say migraine, thinking of it as a chronic condition where people can have episodic attacks, but it still impacts their quality of life even when they're not in pain.
This is Dr. Rashmi Halker Singh from the Mayo Clinic.
I'm a neurologist. I'm a headache subspecialist, and I spend a lot of time seeing patients. And the main question that they have is, how do you know I have a migraine, and how is that different from headache? The big thing is migraine is so much more than just head pain.
So much more than head pain. Those of you who have migraine know this already. And for the rest of us, this episode is going to be an education. So here it is, by popular demand, a Migraine and Hormones 101 episode, where I think you'll improve your basic understanding of this condition and come up with some smart and specific questions to ask your doctor during your next visit. This is a really practical conversation, and it covers migraine from puberty to pregnancy to perimenopause, all the important P's, and some surprising facts about migraines with aura. Dr. Singh has a great way to think about treatment as well. I'm also writing about the backstory to this episode in my newsletter, so make sure you're signed up for that. My conversation about migraines and hormones with Dr. Rashmi Singh is coming up in just a minute.
Are you curious about what it's like working in healthcare today? Do you believe in the power of storytelling? I'm Dr. Emily Silverman, the host of the Nocturnist podcast, where healthcare workers share personal stories of joy, sorrow, and self-discovery. Each episode, whether a compelling performance from one of our live shows, an intimate series of audio diaries from one of our documentaries, or an engaging conversation with guests such as book authors or filmmakers, aims to connect, provoke, and inspire. Learn more at thenocturnist.com or subscribe to The Nocturnist wherever you get your podcasts.
Dr. Singh, hi, and welcome to Overlooked.
Thank you so much for having me.
I'm so pleased to do this interview with you, and I'm so glad that you made the time. I want to start with a really 101 question and ask you, what is the difference between a headache and a migraine?
That is such a great question. First of all, thank you for bringing me on because this is a really important topic. It affects so many people. In fact, about almost 1 out of 5 women is affected by migraine in her lifetime. I will also tell you that I make a new diagnosis of migraine every day in my clinic. First of all, we do diagnose it based on headache symptoms. So there are formal diagnostic criteria to make that diagnosis. Every diagnosis we make is based on something called the International Classification of Headache Disorders. So it all comes down to talking to our patients, listening to their story, truly listening and seeing if their symptoms sound like migraine. But in a nutshell, people need to have a recurring headache problem where the pain is moderate to severe, can limit them from activity, and they can have other symptoms along with that, like nausea, light or sound sensitivity. That's basically the gist of migraine. And I'll also share some of my own patients tell me it's not just the head pain, but it's really everything else. And I think a lot of listeners can relate to that.
It's a pretty debilitating thing, right?
Yes, this is why it's a chronic condition because people with migraine don't know when that next attack will happen. I can put myself in your friend's shoes. If I had an attack like that, say once a week, and I don't know which day it's going to be, that would cause such debility for me, right? I wouldn't be able to plan anything. I wouldn't be able to make any like professional commitments or even commit to my family or do anything. And so that's what we call about the disability of migraine, even when the pain is not present.
Right. So let's jump into hormones then. What do we know right now about the connection between hormones and migraine?
So we know a lot. So migraine affects about almost 1 out of 5 women. It affects about 6% of men. So there's this big gender difference. About 1/3 of women will have their onset, their first migraine attack around the time of puberty. About 2/3 of women will say that they have a hormonal relationship with their attacks, meaning they're more likely to have attacks with their menstrual cycle. And those attacks are often the worst ones that they experience. It gets better for many women when they're pregnant. About 2/3 of women will say that when they are pregnant, their migraine attacks improve, and then it can come back after delivery. And perimenopause is a time of migraine worsening for many women. And for many women, migraine attacks can improve after menopause. So what this really tells us is that there's a relationship. It's with estrogen and specifically estrogen fluctuations. So that's what we know about migraine and hormones. We actually have data that 1 out of 5 women chooses to avoid pregnancy altogether in her lifetime because she carries a migraine diagnosis. And that has a lot to do with this misunderstanding that many women think that, there's a lot of reasons as to why that happens, but some women are not sure how they would manage their attacks. They don't know if they would be passing on migraine genes. They don't know what medications they can take. They don't know a whole lot. And I think it's important to let women know that for many women, migraine attacks do improve during pregnancy. And this should not be something that stops them from getting pregnant if that's something that they want to do.
That's the stunning piece of data, Dr. Singh. Can you tell me a little bit more about that? Because that's really where you're really under the thumb of a chronic condition, right? To the point where you're making a different set of life choices. So tell me a little bit more about that data.
Yeah, so there was a large clinical trial. It's called the ARMOR study. It's a patient survey study where, so many women were surveyed about so many different things. And one question asked about their thoughts about pregnancy and family planning. And we learned through that 20% of women who carry a migraine diagnosis chooses to avoid pregnancy altogether because of her migraine diagnosis. This is a time-sensitive decision in a woman's life. If she chooses to get pregnant or not, this is one of those things you can't be 60 years old and decide I want to do this. So there's a window that you have. And I want every woman to make the choice that she wants because of personal reasons, not because of a migraine diagnosis.
Yeah, that's a very surprising piece of data. I want to ask about another condition that I've heard and have you explain to me what it means and what's the difference, and that is migraine with aura. So can you say a little bit more about that?
Yes. So that's actually really interesting too. So when we talk about migraine, I just spoke that migraine is so much more than a headache. And actually there are phases to a migraine attack. About 80% of people who have migraine will have symptoms before the pain even begins. That's called the prodrome. And it can sometimes be very subtle. They might feel that lights are very sensitive. They might have early nausea. They might have food cravings. It can be a lot of different things. This can start maybe 1 or 2 days before the attack. It can start like 6 to 8 hours before the attack. I'm going to come back to why prodrome is very important in just a minute. The second phase of migraine is called the aura. About 25% of people who have migraine can have this. It lasts anywhere from 5 to 60 minutes. We define this using some medical words as stereotyped neurological symptoms that are reversible, meaning that you will see something in your vision, like colorful lights, kaleidoscope vision. You'll see spots in your vision, or maybe you'll experience tingling up one arm, things like that. And then the headache phase happens. The headache can either begin with the aura or right after. And that typically lasts anywhere from 4 to 72 hours without medication. And then people can have a postdrome, or what we call, my patients often refer to this as the headache hangover. It's like the recovery phase. It can be characterized by milder pain or even like cognitive dysfunctions. The brain kind of recovers from all of this. Aura is considered to be genetic, and it has some implications because women who have aura, there's some discussion about whether they can be on hormonal contraception or not, specifically ones that contain estrogen, because aura is thought to increase a person's stroke risk factor, and estrogen might be able to do the same thing. I want to clarify, though, just because what I found in my clinic is that many people, when they say they have aura, if we as doctors don't ask more questions about what they mean by that, we are actually misdiagnosing prodrome symptoms as aura. And they're very distinct because if a person has prodrome, they can take hormonal contraception. I've actually started asking my patients about this because I think it can be empowering to be able to recognize your prodrome symptoms, because there is data now that if we treat migraine during that very first stage, we can avoid the rest of it.
Wow. Okay. So the science is kind of still moving, still evolving on this then.
Oh, yes, yes.
That's exciting. It's really interesting. I did a series on women's health history. You know how we talk about women's history every March. And women's health history is like not history. It's happening right now, right? We're kind of the strides that we're making. I know it seems bleak out there in many ways, but I think overall we're kind of moving at least in the right direction. So that's really good to hear. Let's relieve the suspense for people. Let's talk about treatment options. Tell me a little bit more about how this can be treated and what's new in this respect.
I mean, there's no better time to be a doctor who takes care of people who live with migraine than now because of all the things that we can offer our patients. Every patient that has migraine, talk to them about lifestyle, non-medication things that they can do to help themselves. The mnemonic that we like to use in our practice is called the seeds to success. So the first S stands for sleep. Basically, people who have migraine, they really do well with consistency. So all these things I'm going to point out have a lot to do with consistency. So people who have migraine really do well with consistent sleep every single night. If a person's getting erratic sleep, like too much sleep one night, not enough sleep the next night, that can set them up for having more migraine attacks. And then the next letter is E for regular, consistent eating of meals. And sometimes caffeine cessation too, because for some people, too much caffeine or daily caffeine can be a risk factor for the development of daily headache. The next E is exercise. So regular, consistent exercise is a healthy habit, including for migraine prevention. The next letter is D for diary, just because sometimes taking too much as needed medication, by that I mean literally anything that's intended to be used as needed for pain, if it's used more than 10 days per month, can actually make migraine attacks more frequent. And then the last letter is S, which stands for stress management, because those areas of the brain that are responsible for emotion feed right into the pain pathways. So if we think of maintaining consistency, that can be helpful. Beyond all of that, of course, every person who has migraine should get appropriate as-needed medication that they could take when their attacks come on, either at the start of their prodrome symptoms, if they can identify, or at the start of their migraine attack. triptan medications, which have been around for a while, are still first line. And there is data coming out that they could be used possibly by women who are pregnant as well. So I always talk to my patients about that data. People who can't take triptans because they should not be taken by people who've had a heart attack or stroke, or maybe they haven't found them to be helpful or they've had side effects. We have newer medications as well. That class is called GPANTs, and there's a few different options. So there are a lot of things that people can use beyond the things that are available without a prescription.
That is really interesting, that mnemonic that you came up with. And in my head, I sort of thought about the last one, which is stress, right? And to be a woman in 2025 and get stress under control is
Oh, yes.
it's like it's a lifetime commitment to keeping your cortisol levels down. But it's kind of interesting because in what I heard you say, Sally, for example, has by trial and error figured out some of those things. It just seems to me, someone who's never had migraine, that there's this feeling of powerlessness about this, right? When you feel it coming on, you sort of know the direction that it's going in. So there's like the predictability of that. You know it's going to get bad. And there's the unpredictability of knowing, well, I don't even know when it's going to hit me. What do you say to your patients to help them feel less powerless in this respect?
Migraine can be a very isolating condition, because people often feel best when they have their symptoms in a dark, quiet room, not moving. So I think the first thing I think I want my patients to know, or anyone who's listening to know, is that they are not alone. I think it's actually a really important message, given that this can be an isolating disease process to live with, that they are not alone. There's a strong community. This impacts over 1 billion people in the world. And I also want them to know that there are doctors who also understand, as well as a big community of advocates as well. And I think how they can help themselves is to get involved, educate themselves about their condition, and stand up for the things that they need, because we have so much that we can offer and we're here to help.
Awesome. I want to ask you a question that I think is on a lot of people's mind. It's a yes/no question, but feel free to develop it out. Does perimenopause worsen migraine?
It does. Perimenopause is a time where migraine worsens because that's when estrogen cycles are erratic. Additionally, there is new data that having a migraine diagnosis can lead to a worsened perimenopause experience. I will add, there is data that surgical menopause can lead to things worsening as well. This is an area where we need more research to help our patients, though. I think it's a big deal that, women live it's like half of our lifetime for like half of the world's population, and we need more research on this.
Throughout our conversation, Dr. Singh, I've heard you refer to your relationship with your patients, what you tell patients, the resources that you like to bring them. I think your patients must be extremely lucky people, because you seem like a very engaged doctor. And unfortunately, I still hear from so many people, women my age in our 50s, have this story all the time. I went to my doctor to say my chest really hurts in the middle of my perimenopause journey. It's like, I feel like there's like a tightening in my chest. Doc, what should I do about it? He looked me in the eye and he said, don't worry about it. I'm sure it's in your head. So, there are still these stories that are going on. What do you say to patients, or what advice do you have for patients who have migraine, who are going in to see a doctor? And what do you say to them about how they should communicate their symptoms, or what they should be looking for in a doctor from that sense, so that those symptoms are taken seriously and acted upon and they can get some treatment options?
Oh my goodness, I'm so sorry to hear about those experiences. I don't want to put the onus on the patient, though. That's the thing, right? Like, this is not the patient's fault. I think the best thing that they can do is be their authentic selves, to come in with their true story. Sometimes it does help to write down symptoms, write down things so that they don't forget things. Take notes, especially if it's important. Bring a support person with you who can be an extra set of eyes and ears and be your advocate in the moment as well. Because sometimes it's difficult to speak up for our own selves, but somebody else can speak up for us when we need that. I think those things can be very helpful. And if you feel like you're not heard, then maybe it is a good idea to seek a second opinion.
Mm-hmm, mm-hmm. What do you think is the most overlooked aspect of migraine? And where is that inequality that's created as a result of being overlooked? Where is that felt most deeply, do you think?
That's such a profound question. There are so many things that we need to do better from a migraine standpoint. I think I have a list, you know? So it's a little hard for me to simply answer that. But I think we need to do a better job for our younger patients because I really care deeply about this younger population, thinking about the fact that this is a critical time of their life that they can't get back and impact their trajectory. So we need more treatments for them. I really care about the non-headache symptoms and being able to make that appropriate diagnosis and being able to help those symptoms as well. We also know that so many people live with migraine but don't have an appropriate diagnosis. And to resolve that disability, getting that diagnosis is the first thing. So there's a lot that we need to do better.
Okay. And then the last question that I have for you is a little bit of a personal question. In doing the work that you do, is there a personal motivation behind it, either a personal experience with migraine specifically, or some kind of driving force that keeps you doing this work that is rooted in a personal experience?
I came into migraine because of my patients. I love talking to my patients. I love being there for them, listening to their stories. This is a journey. Migraine is a genetic problem. That's why people have it, and they live with it mainly for their lives, but it can affect them differently. And I love taking care of women. So those are my passions. That's what brought me into the field. Later on, my child did develop migraine. She's now 20, but I've been doing this a lot longer than her diagnosis. But I think being a mother of someone who has migraine has given me added empathy as well and an added dimension perspective.
Well, that's beautiful. And it's kind of interesting that when you talk about your child as well, because I, throughout this interview, have been thinking about my mother-in-law, who's not with us here anymore. But she used to have migraine that kept her locked in a room for 2 days, 3 days. And she was from a generation of the women that came before us where we were not having these conversations and we were not moving the needle in science in the way that we are now. And it just makes me feel a little bit rueful that, God, I wish we had it back then. But thank God we'll have it for the next generation, for your child, for moving forward as we kind of develop this research more, as we have these conversations out loud, as we seek to have like a different relationships with our doctors, with our own bodies. It's like a little bright spot in everything that's going on right now. And I'd like to hold on to it.
Me too. Thank you so much for shining a light on this really important topic.
Overlooked is here for information and empowerment, but not medical advice. Every person's body is unique. So if you have questions, it is best to speak to your doctor or healthcare provider. We're building a community around women's health so that no one is overlooked. If you'd like to be part of it, hit the follow button on this podcast, wherever you're listening to this. Or you can show us some love by writing us a review and sharing this episode with someone. Overlooked is written and created by me, Golda Arthur. Jessica Martinez de Hoz is the show's producer. You can stay up to date with the show by signing up for the newsletter and following us on Instagram and LinkedIn. We read every review and email, so write to us, hello@overlookedpod.com. Thanks for listening.